Happy Thursday Night Live. Look who I have with us today. The one and only Dr. Karen Parker Davidson. What's up, girl?
Thank you for having me. Oh gosh, what's up? Don't even get me started.
When was the first time that you spoke for us?
Oh my gosh. So happy fifth anniversary. Can you believe it?
No?
So have a little recap here. Okay. February 2021, you reached out to me and I had no idea what myofunctional therapy was. I'm like, myo, muscle. I mean, I knew enough to be dangerous, right? But not enough to be reassured. I'm like, myo, muscle, functional movement, muscle movement. Okay. And then I learned so much from you. And you were just getting airway circles started. Fast forward, you gave me my first opportunity to speak. I was so nervous. I was like, thank goodness no one could see the sweat beating off of my forehead because I'm not a public speaker. I'll be the first, I'm not a public speaker, but yet I was a cheerleader all the way up to college and a dancer. Now, figure that one out. Okay, so I can dance, but just don't make me speak. And so later on, you were telling me get on Instagram. I'm like, ugh, social media. I'm like, okay. So my first talk was the nose knows, and you said,
Yeah.
"There's your handle, the nose knows." Well, it was taken, so now it's underscore the nose knows, and that is how the nose knows got started.
And how many followers you have now on Instagram?
About 135,000,
I know. That's crazy.
and
It's
about
so cool.
almost 10,000 on LinkedIn. I haven't broken the waves of TikTok, y'all. I just
Me
can't.
neither.
I'm not there. I'm not there.
I'm
But if
not
you
a
can
huge
help
fan of
me,
TikTok because I don't use it. I use Instagram a lot, so I want to be in there, not. But
yeah.
TikTok still
Whenever
hasn't.
I hear TikTok, it always reminds me of that song back in the 80s, TikTok, you don't stop.
Ah, but I
Okay,
am so proud of you.
now I'm dating myself. But yeah, thank you. I mean, you
Congratulations. And you have
really helped me
written
get
some.
this whole thing started. And like friends, we're colleagues, but we're friends. And I giggle because we get mad at each other and like go in our corners and then we come back.
Yes. And we have an incredible friend in common that we both lost, that we love dearly,
Oh my
that
gosh,
was part of our lives for,
Yeah,
you
Martha
know,
Cortez.
such a
She
short time.
she was such a true champion of what you did because she was on the Clubhouse app,
Yes.
right? And and that's how I met her was through you on Clubhouse. She was the biggest champion of my work with rhinomanometry.
Wow.
And just to kind of touch on that, the rhinomanometer, I mean, it's been around for about 20 years or so. I mean, the history goes far back, but the multiphasic has really become dominant. And I brought it over here to the States consistently, commercially back in 2017. So it's been quite a journey, created the algorithm because my critical care flight nurse brain was like, I'm a curves, waveform kind of person. I mean, that's how I function. I look at waveforms to know like if my intracranial pressure is changing or mean arterial pressure is changing. And mean arterial pressure is like your real live blood pressure. And I can tell if someone's going down fast. And so I went to the owner. I'm like, how do you do this interpretation? What does all this mean? And so over 5.5 years, I really studied this. Now it's been 10 years. And it's quite fascinating what we can see, what we can do with it. And I just get so excited and passionate to teach it to as many doctors as I can because it's such a valuable tool. In addition to imaging and CBCTs and X-rays and MRIs. So that's how our 5 year anniversary started, and here we are.
I
Gosh.
know. It's so crazy. Now you have your own podcast too.
Yes, so the Let's Get Nosy podcast, hopefully
I
this
love that.
summer, I'm trying to get book number two out. And book number two is called The Nose Decoded, Unveiling 60 Functions, Muscle
Wow.
Functions that Impact Our Health. It was kind of a funny story. So my mentor was Dr. Klaus Vaught, and we lost him in November. Gosh, don't cry, don't cry,
Oh,
don't cry.
so
But we lost him
sorry.
in November. And he was my co-researcher. We wrote papers together, and he really championed my work. When I told him I could interpret and do a whole logic and algorithm of the data, he said, no way. And so in 2024, he was friends with Maurice Cottle, Dr. Cottle, the
Yes,
Cottle Maneuver.
maneuver.
And he was also friends with CG, Dr. Gimeno. In fact, he made Dr. Gimeno his own personal four-phase rhinomanometer. And the story goes back to 1989, where CG was asked to speak at a conference in Riga. And he said, I'll only come if I can meet with Klaus. And I have a picture of CG at dinner with Klaus. Yeah, yeah.
Aww.
So that was in 1989. But it was really interesting because you hear all these different functions and it gets into nasal care. But I asked him, I said, Dr. Vaught, are there really like 30 functions or you hear 30, 33 functions of the nose? And he was like, bah, you know this nose better than I do. You tell me. And it was winter here in Maryland. So I got my phone and just started talking to my phone. A few passerbyers are looking at me like I've lost a few marbles. Occasionally I do. And I just started talking and I broke it down into six parts like respiration and oral facial and all these, immunity. And I came up with 60, actually 63. So this
Wow.
thing just goes on and on and on and on and on, which brings us here today about nasal care and how much we have to keep that in focus. I see patients, so I'm licensed and through compact licensure in 44 states and territories. And one thing I tell my patients, sorry, social media people, influencers, but I tell them, get off of social media. And I have to myself because I get on there and I'm like, what is that snake oil? And we'll get into that because we have to look at things from a regulatory perspective, like what's real, what's not real, what to do, what not to do, and where do I go for the right answer? So here we are.
Wow, wow, wow. We can literally stay here all day because me and you, we love talking. But
Right?
let's go ahead and start our presentation. And I haven't even introduced you yet. Hold
Oh
on.
my goodness. Okay.
Let me introduce you. Oh, I clicked on something that I shouldn't have clicked on. Hold on. Okay, here we go. Ta-da-da, ladies and gentlemen, presenting Dr. Karen Parker Davidson, an RN, the founder, actually, you're nurse practitioner, right?
Clinical nurse specialist.
There you go.
Advanced practitioner, but yeah, clinical nurse specialist.
The founder of the International Society of Airway Function Diagnostics and Therapeutics, and a globally recognized airway clinical nurse specialist. She is a leader in nasal function and airway diagnostics, pioneering the use of nasal resistance as a vital sign to guide treatment and improve outcomes. With nearly 40 years of experience, she started when she was 12. She has developed tools like Airway AI and the Davidson Maneuver, which I've been teaching to my patients, and serves as a CEO of MedTec Research. An author and international speaker, Dr. Davidson is recognized for her groundbreaking work in airway health. Today's topic is nasal care in focus, evidence-based products, pitfalls, and promises. I cannot wait to hear this. You're welcome to share your screen. Welcome again to the Airway Circle stage. This time they can see us.
Oh my gosh. Thank you, thank you, thank you for having me. It is a pleasure. So let's get this party started
Let's go.
from the beginning. So, Renata, thank you again for having me because I get really passionate about this. Like I said, there's so much stuff. How's that for a medical term? There's a lot of different things on social media. And I just want to bring a perspective to it so that people have a better understanding and don't get caught up in some of the woo woo or foo foo kind of things. So, here are my full disclosures, financial, non financial. And what we're going to learn today is looking at nasal anatomy, physiology, fundamentals, which we all know for the most part, but we really want to get low down and dirty, looking at nasal products, mechanisms of actions, differentiate between evidence-based therapies and unsupported treatments, and look at the misuse patterns, FDA regulatory, like what's real, what's not real. So here we go with anatomy, the basic anatomy. We know nasal septum and the turbinates, and the turbinates give us more of a total surface area in the nose, so that we can have air coming in, humidify, moisturize, the whole realm of breathing, what we need. And it's a huge vascular supply. In trauma, in my trauma days, we call this the triangle of death. God, that sounds so morbid, but it really is a triangle of death. I mean, when you do self-defense and they tell you just go like this, you can literally push someone's septum into the brain. I mean, you can really hurt somebody, but it's so vascular. And to go back into my ENT days, I've been in the ENT world at some level since 2002. And 8 years of that was with as a vendor with different medical device companies, actually two. One of them is now Olympus. So, but what was interesting those 8 years, I saw over 8,000 ENT procedures in the OR and in the office. And one thing, and we'll get to it, but um, one case is it's a procedure called polypectomy, and they put polyps in there, and they use like a 4 millimeter sinus blade. So it's like a little drill with a little blade that oscillates and takes that polyp down. That is bloody because it's attached. It has like a stalk attached to the mucosa, and it's a really bloody case. So it's so highly vascular. But our friend, the largest cranial nerve, the trigeminal nerve, we have sensory in the V1 and V2. But we have motor in V3 with the jaw. And this is where this all kind of comes together between medical and dental when we look at nasal function and nasal resistance. So when we look at these different functions, again, nitric oxide production, filtration, humidification, mucociliary clearance, all of these components can impact how we do nasal care. So for example, mucociliary clearance, it can actually slow down with some diseases. Nitric oxide, I just have to put this to rest. You hear nitric oxide production in the nose. Here's the reality. Most of nitric oxide is produced in the vascular system, endothelial cells, but the highest concentration of nitric oxide is produced in the paranasal sinuses. So not the nose itself, but the paranasal sinuses. So just to repeat, the highest concentration is in the paranasal sinuses. The highest production is in the vascular system. And what's really important in trauma, like hypovolemic shock, when you're bleeding out, the liver kicks in and also produces nitric oxide, as well as the gut. So you can see how these functions all come together and they have to work in sync, almost like homeostasis. Our whole body has a pH. Our blood has a pH. It has to be within that range and balanced. So when we look at the nose, I consider it a reactive organ. It's a pressure regulator. How much negative pressure and air comes in, how much goes out, how well we breathe, our patterns of breathing. And I could go down a rabbit hole with this. But what's really interesting is that 85% of upper airway respiratory illnesses are viruses. And that can translate into about 4.2 million deaths a year and 20 million work days lost each year and millions of physician visits a year. Congestion, nasal congestion is the number one condition or symptom that is seen in offices. So where did all this nose, why the hype? What happened? A lot of it goes back to COVID. So I was part of the Harrison COVID-19 research group, and we did have the opportunity to present to White House staff our approach for COVID treatment. And it was through a nasal spray, actually. And it was over the counter and also an over the counter protocol, which we still have on our website. It's at Harrison COVID-19 researchgroup.com. So you can kind of see what we did. But ever since COVID, because we looked at how the virus comes in and it implants itself, it goes through apoptosis and breaks down, and then we inhale it. That's the simple version. But it seems like the pandemic, the nose is now such a huge component of our conversations, as well as it should be, right? And I think, when James Nestor, when he brought out the book Breath in 2020, that kind of impacted and added more added value to what we're doing. So right now, when we look at the nose, most of our customers are allergy, CPAP, surgical, a lot of oncology patients, believe it or not, and respiratory sufferers. But here's one thing I really want to hone in on. We have good bugs in our nose. And I'll get into this when we talk about nasal irrigation, because I get a little overly protective of my bugs in the nose. These are the normal bacteria that we have, and we need these bacteria to protect against the harmful pathogens that could disrupt our healthy nasal microbiome. And you can see here Staphylococcus epidermis. They each have a purpose. That's a protective skin nasal uh, collaboration right there to reduce that harmful bacterial colonization. But the key concept here is that we have to maintain a microbiome modulation and reduction of pathogen outgrowth. And that's what we have to look at. So we have our good bugs. We need these good bugs. We can't live without them. That's our normal nasal flora. And again, it helps in our immune regulation, mucosal barrier protection, and competes against the bad bugs. And these are the bad bugs. These are the ones that give us the risk of infection, inflammation, post-operative complications and sinus surgery, or even poor surgical outcomes, even poor orthodontic outcomes as well. So our most common nose issues are allergic rhinitis. Here's just a few fun facts. I wrote a paper in 2019. The citation's down there. I was published in the Journal of Allergy Disorders. And what's really interesting is that I wrote about objective measurements. Are we doing enough for patients? And the short answer is no, not really. We do a lot of subjectivity. We do questionnaires. That's a great thing. I use them in my office. It gives us a cue as to what brings you here today? What is the patient's perspective? And that's the conversation we have to have, is to understand the patient. So in my world, when we look at allergic rhinitis, 10 to 20% of the global population has it. And 80% of those with rhinitis will have it by the age of 20. So if you're a child with rhinitis, you're in that 80% category that's going to have it by the age of 20. But then we also have non-allergic rhinitis, where it's not really an allergic trigger, but it could be a vasomotor rhinitis. And then we have sinusitis, obviously, inflammation of the sinuses. And then we also have dry mucosa, where we don't have enough adequate moisture in the nose. And we get a little crusting. But here's the key distinctions, is that the allergic rhinitis involves an IgE-mediated inflammation. Non-allergic rhinitis can be triggered by irritants, the weather, or hormonal changes. Ladies going through menopause, this goes out to you. Sinusitis, it's usually following a viral impact. This is really important because you'll see a lot of antibiotic conversations on social media. Most sinusitis is caused by a virus. And now in the protocols, there's really no antibiotics given until 7 days of symptoms. And that's changed over the years. And a lot of it's because we don't want to have any type of antibiotic resistance, which was a huge conversation when I sold anti-infectives back in the late 90s. And what's interesting is that Dr. Pearl, who is at Hopkins and University of Maryland, when I sold anti-infectives, specifically I sold Levaquin, which is a quinolone antibiotic. It's a big gun after the smaller ones. And I remember I was talking about antibacterial soap. And I was so hooked on antibacterial soap. And Dr. Pearl's like, stop it. Stop using antibacterial soap. You're washing away the good bugs we have on our hands to defend our body. And that was really impactful. But also, going back to the nose, dry mucosa is very common in low humidity environments. So we have to, it's a balancing act of so many different things. But again, nasal congestion is a common symptom seen in clinical practice, the most common actually. So let's get down to the products. There's several different categories. There's an influencer that I really like, Dr. Z ENT. She's Stanford trained, and I think she's still practicing at Stanford. She's done a really good job on a few posts with different nasal sprays and what they do. So if you have any interest in learning more about this, hop on over to her page on Instagram. It's Dr. Z ENT. But she did a really good job explaining them at a really lower level for a lot of people. So we're going to explore some of the saline sprays, irrigation, and really understand how each of these products integrate. So we look at nasal care products. We break them down into saline sprays, nasal steroids, decongestants, antihistamine sprays, and barrier gels and ointments. And each of these categories has a distinct mechanism of action and evidence levels and safety profiles that guide the appropriate clinical selection. So let's start with the saline sprays. This is very common. They're a cornerstone of our nasal care. They have an excellent safety profile. There's two main types. The isotonic means it is the fluid concentration that is similar to our body fluid. So that's 0.9% normal saline that we usually see like in IV bags in the hospital. And it's a gentle daily use. Then there's a hypertonic saline, and that's a 0.3%. That draws out fluid and helps reduce congestion. But here's the caveat. There was an influencer, a medical doctor, who was saying flush with hypertonic fluid or irrigate with hypertonic fluid. It can decrease the number of days of a viral infection. I'll be honest with you. I've never used a hypertonic saline in the nose. The only time I used a hypertonic saline was in the ICU. That's all I'm going to say about that. But the most common one is xylitol, clear spray. That's also homeopathic, which we're all familiar with. So basically, that's the mechanism of action there is just cleaning and removing the different allergens and irritants and debris, restoring moisture into dry passages, supporting natural mucociliary, clearance and function. They're non-medicated, non-addictive, and they're safe for all ages, including children and pregnant women. And that's very, very important to consider. But also, anything that I say here is not medical advice, so please always check with your provider. In our house, we use clear spray. It's in my son's baseball bag. It's in my purse. It's in my office. When I do rhinomanometry testing and I look for nasal provocation or the decongestion portion of nasal function, I use clear spray is what I use. Here we go to the irrigations, neti pots, lavage. We see these different things. The Neomed, the squeeze bottles, how they can offer a controlled pressure irrigation. Now, this is really good. I like them in the presence of mucus. I'm not a huge fan of these every day for prophylactic use. If you go back to my previous slide talking about the normal flora that we have in our nose, those good bugs to defend the bad bugs. This is why I'm really cautious about irrigation, not saline rinsing, but actual irrigation where we're just shoving fluid into the nose to get that mucus out. It is good when we have mucus. And you've seen the videos on social media, the little toddlers with about a 10 cc of a syringe of, pushing in this side of the nose, it's coming out the other nose. And it works. It really does work. But again, we want to use that in the presence of mucus when it's really heavy. Again, because over rinsing can have these disruptive effects on that nasal microbiome and the protective mucus barrier. And you can see here, some of the potential effects can include dryness or irritation of the nasal lining, increased inflammation. So it can also have a reverse effect. It really can. It can have rebound, congestion, and swelling. And these are good because in the ENT world, for example, polyps, we would use like aerolized budesonide to bring polyps down. But there's budesonide rinses that ENTs will prescribe. So your patients may have prescription irrigation protocols from their ENT, and always check into that as well. But again, with those also have adverse events as well. But what's really key is that if we keep rinsing, we can also alter our nitric oxide balance and impair that nasal defense. So the key concept is we want to keep our balance with irrigation and not sterilize our nose. And then we get into the corticosteroid sprays. They're a gold standard for allergic rhinitis treatment, and the mechanism of action is it's a very powerful anti-inflammatory to reduce that nasal inflammation. It is recommended by ARIA, and ARIA is the allergic rhinitis and its impact on asthma. It's an international guideline that a lot of doctors will talk about, and I did refer to this in my first paper back in 2019, looking at global allergic rhinitis and how it does impact asthma. But it treats congestion, sneezing, itching, rhinorrhea, which is runny nose, minimal systemic absorption when they use it as directed. The full effect typically is within 1 to 2 weeks with consistent use. Some of the common options are fluoroconase, mometasone, budesonide that I just mentioned. But the proper technique, and this is something we'll touch on too, is technique. These sprays are great, but what about technique? We want to spray away from the septum this way and just a gentle inhalation. As far as long-term use, it's safe for extended periods with appropriate monitoring, but the key point is it has superior efficacy compared to oral antihistamines for nasal congestion. And then we want to talk about decongestants. Ha, Afrin. It's like a four-letter word in the ENT world. So as a flight nurse, I used Afrin. It was like my go-to to prevent sinus block or ear block at altitude. And I did a talk at Panny talking about altitude and pressure changes in our body when we go from sea level to at least 1,000 meters, which is about 3,000 feet or so. That's because there's a 10 to 12% drop in barometric pressure changes that really disrupts our whole pressures in our body and how we breathe, and as well as nasal resistance. But the decongestants, like Afrin that everyone knows, provide that rapid relief just like that. It's a very short-term use. We say 3 days. Some people say 5 days. Always check with your doctor. But here's the problem. Because they work so fast on the vasculature of the nose, they have that higher risk of a rebound congestion with prolonged use. And that's why people will say, well, I used it, but then I couldn't breathe again. That's because it's very strong, it's very anti-inflammatory, and it works so quickly that it just kind of rebounds. Then we have antihistamine nasal sprays for a targeted relief for allergic rhinitis. And a lot of compound pharmacies will do these different kind of combination medications, but the mechanism of action is to block the histamine receptors locally in the nasal tissue. They're pretty fast acting within 15 to 30 minutes. They effectively reduce sneezing, itching, and rhinorrhea, runny nose. And you have like Astepro, Pananase, some mild side effects where they might get a bitter taste. That's very common. A little bit of drowsiness, maybe, or nasal irritation. But the advantages over the oral forms are a faster onset, higher concentrations, and fewer systemic effects. Safe for daily use without the risk of rebound congestion. And then we have our combination therapies, which is very common. And they have these compounding pharmacies where they'll send it out to the patient. They'll do like a telehealth visit or a questionnaire. So when a monotherapy fails, that's when we can jump in and do a combination therapy. So we could do a corticosteroid with an antihistamine, faster onset than just one single agent alone. And a lot of these are FDA approved for seasonal allergic rhinitis. A lot of clinical evidence is out there when looking at total nasal symptom scores. It is superior to a monotherapy. And we look at these as far as ideal candidates. We look at refractory allergic rhinitis patients, meaning they have these reoccurring allergic reactions. And what do we do? This is an option here. Those that have both congestion and rhinorrhea, and patients that are really seeking a rapid and sustained relief. So here we go. I gotta say this. We really have to look at evidence-based outcomes across these different products. When we look at steroid sprays, they're the most effective for allergic rhinitis with 30 to 40% symptom reduction versus a placebo. And these are in controlled trials. And then we have also the combination therapies that also show an efficacy in refractory cases. It's a faster onset than just using one type of treatment. Antihistamine sprays, rapid relief within 15 minutes, effective for sneezing. The saline irrigation, again, consistent evidence for symptom improvement, excellent safety profile across all populations. But then we have the decongestants, and that's a high initial efficacy, but limited to short-term use because of those diminishing returns 3 to 5 days after. Now, Renata, this is one thing you wanted me to touch on, gels. So here's a new concept with gels and petroleum jellies. So we really want to look at the barrier gels, any type of safety concerns, the evidence behind them, and we have to say this: the risk of lipid or lipoid pneumonia. Lipoid is pneumonia is droplets of petroleum jelly that get into the lungs and create a pneumonia. So the most popular one, and a lot of people are inquiring, is nasal cleanse gel. Now, claims versus evidence. I will just tell you that I like this. I've done research for them, with them, and I have presented at World Allergy in 2025 and the American Academy of Otolaryngology head and neck surgeons in September of 2024. And we've got more coming out. So all of our posters were presented at these two conferences as well as published in the Journal of Allergy. Yeah, it's a big one. But nonetheless, so it's new to the market. It does have a moisturizing and protective aspect to it. The marketed claims it creates a protective barrier against irritants and allergens. It smooths and moisturizes the dry nasal passages. Now, as far as evidence, because it's new, anything that's new has a limited amount of peer-reviewed clinical studies. That's okay. That's okay. Our studies were small scale, 16 patients, 10 patients. But the point is that we did it and we presented it. So the evidence is out there. Clinical considerations, it can have a symptomatic relief for nasal dryness. There are some bacteriostatic properties, meaning it did have a bacterial eliminating effect to it. And it also improves nasal resistance and airflow. I did the study, did the publishing. It's there. But as clinicians, we just have to kind of weigh things out and weigh our options out with all of our different patients. You all know this guy. But this is what it looks like. It's a wand and a gel system. It is patented and it does have a cleaning effect to it. So it's anatomically designed. It has a little whirly type of wand there, and it's physician formulated by an oncology breast surgeon. Believe it or not. But that tip is soft and flexible, and a lot of times you can just rewash it if you need to. So yeah, that was Zach. He was part of our poster, my poster child. uh,
So really quickly, yes,
yeah, yeah.
I just wrote in the comments, so handsome. We see your child and so talented.
Oh, my
Um,
baby. So I have to give him a shout out. He was carrying a 4.0. He's my Airway Y, y'all. And
what?
he was carrying a 4.0 GPA 2 semesters in a row. Of course, being
Wow.
a professor myself, I was on him about the grades. I'm like, grades before girls, student
Ah,
athlete,
there we
student
go.
before athlete. And he just committed to Towson University, a higher end D1 school for
Yeah.
baseball. So
Oh,
I'm so
congratulations.
stinking proud of him. I do measure him. He does have allergic rhinitis, Renata. And I
Wow.
do measure him in my office, and he does the clear spray. He has done expansion. He's done Invisalign. So he's my
Mhm.
airway baby.
Amazing. Really quick, I know that you're not done, but I have a couple questions already.
Yeah, yeah.
You're mentioning that the clear spray the hypertonic solution, or is it an isotonic?
Isotonic because it's
Okay.
saline. It's got saline, grapefruit, and something else in there. It's
Yes. I
isotonic, so
thought
it's
so.
got normal saline. So it's
Okay.
balanced into our body fluids.
What are some examples of the hypertonic?
It just comes in as hypertonic. In the drugstores, it just says hypertonic solution.
Okay. Okay, perfect. But
And you'll
those
see
are
it'll say 0.3% on there. Yeah.
perfect.
Like I said, that really dries up. And sometimes they'll use it, but I honestly, in my ENT world, I haven't seen it a lot.
Mm-hmm.
I heard about the paper and
Okay.
I listened to the one doctor on social media. I'm like, ugh. Everyone's gonna run to the drugstore and go, oh, mucus, and it can really dry out too much and cause crustiness and nosebleeds. So that's why I'm an ISO tonic
Okay.
girl. Just kind of keep as much, as balanced as you can to your normal physiology and tissue balance. Hmm.
Perfect. And this nasal cleanse, it's a moisturizer.
moisturizer, and it does have some bacteriostatic properties, which I'll show you here in a minute. Um, but yeah,
Okay.
so what you do is you put the gel on the wand and you just put it in the nose
Okay.
and you spin it.
Okay, but that's so
Mhm.
it's gel because you mentioned that some studies were showing that Vaseline and things like that were getting in the lungs. So this is different.
This is very different. This is a
Okay.
gel. So it's good. It's anatomically designed, on the wand. It's a barrier gel. It's not petroleum jelly, two different animals.
Okay. 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 Okay.
Mm-hmm.
Perfect. Thank you. You can keep going.
Oh, you're welcome. And now why is my thing not working? Hey,
Because we
my computer froze.
because we stopped. And I was like, let me ask you some questions. This is super cool. I'm looking for it already so I can purchase some and try it out. I like to try everything before I start
Oh,
recommending to my patients.
if you go to my website, it's drkpd.com, drkpd.com,
I love that.
and you go to if you go to the products, those are the ones that I like. And those are just my opinions. All about safety and efficacy. So
Uh-huh.
yeah, those are the ones I like. Mhm.
Okay, awesome, awesome.
And I don't know why
Maybe if you stop sharing and share again, you'll work. Here, I'll pause.
okay, so nasal cleanse gel is currently out of stock. Sorry. It is being reformulated and there's going to be a big launch coming in 2027. And this is Dr. Gail, who is the inventor of it. Again, she's an oncoplastic surgeon. So now she's in the nose. She's really given me a lot of great opportunities and put me on her nasal health council. And we did a few podcasts together. So again, that's everything I have done: podcast research, upcoming research, published papers, books, chapters. I create a depository on my website so you can go and see everything I've done and cut and paste and take you over to the links. The podcasts and different presentations also have links on there already. So take a peek and see what you like. Um, but this is one study that we did when I was telling you about rhinomanometry. We looked at using this product in young athletes. So these were baseball players, college baseball players, and high school baseball players, and we wanted to look at nasal flow and nasal resistance. So what I did is we did, blow your nose, and then I did nasal cleanse gel, and I had a few endpoints to see, does this really work? And following nasal cleansing with nasal cleanse, rhinomanometry did demonstrate improved airflow and a decrease in nasal resistance. Now, this was presented at World Allergy and the Quad AI. So, Quad AI is the American Academy of Asthma, Allergy, and Immunology. And it's a combined visit. So, it's Quad AI and World Allergy. This was our poster. That was, again, it was March of 2025. This was the big poster that we did for the American Academy of Otolaryngology head and neck surgery. And, I'm of the mind that if an ENT approves it, I'm good. Dr. Keith Matheny was part of this study as well as the rhinomanometry study, and he's an ENT in Dallas, Texas. He's one of my favorites. He's so cool. But you can see here that we were looking at pharyngeal, gosh, can't even say it. We're putting this big, long, flexible scope down someone's nose, okay? Um, and we were using this like before surgery as a prep. And basically, a lot of the patients said that was comfortable. Also, when we looked at rhinomanometry, it had a 47% immediate reduction in nasal resistance. So there's, again, another study looking at rhinomanometry and airflow. It also had a 25% increase in airflow after 5 minutes. And really, no significant changes in heart rate, blood pressure, or any oxygen saturation was observed. So basically, the whole concept was to say that the advantages of doing this pre-op was that it was a triple action approach. It was an antiseptic, anesthetic, and lubricating. So putting that flexible scope down the nose was more comfortable. And Dr. Keith Matheny also used this on CPAP patients. And also the CPAP patients, I found a lot more comfort with this because a lot of times that positive pressure air coming in can be drying, and this worked well with CPAP patients as well. And again, that was a study with Dr. Keith. And if you go to the website, I believe it's on the website for nasal cleanse gel. So again, these barrier gels are great for nasal moisturizing, hydration, prevent that crusty in the nose. Very beneficial for CPAP users that are experiencing that dryness, and they do create that protective layer on the nasal mucosa. Here's the devil. Not really the devil, but I have to say this. I saw somebody who does that nasal release technique, and I got to put it out there, y'all. And they said to use Vaseline or Vicks Vapor Rub. Do not, do not, do not, do not put Vicks Vapor Rub in your
On
nose.
your nose.
Ever, ever. It has camphor as an ingredient, and that camphor is very toxic to sensitive nasal tissues. Don't do it. Maybe your grandmother did in the past. Please don't do it. Another woo-woo thing out there is oils. A lot of people are putting like oils under their nose. Even Vicks Vapor Rub. Don't put it under your nose. Don't put it around your nose. Don't put it in your nose. Don't. Peppermint oils have been known to cause seizures. Do your research. Talk to your medical provider. But this has been my experience and what I've learned about things like peppermint oils. We don't put them in the nose either. Now, back in the day in the 90s, when I was working in the OR as a nurse, OR recovery room, I would circulate on occasion. And then in my time in the OR as a vendor and clinical nurse specialist for ENT companies, during sinus surgeries, they use these little pledgets, like little flat white cottonoid things. And they used to just run it over Vaseline on the OR tray, just a little bit, and put it in there. And the whole concept was to, and even on splints, the whole concept was to put that petroleum jelly on the splint and easily guide into the nose. I mean, think about it. You're in there with a sinus drill. It's about a 4 millimeter blade on the end, and it oscillates and just eats up all the tissue. And the patient's going to be sore. So they would use like the Doyle splint or different splints, and they would put the Vaseline on there and put it in the nose. Now, I reach out to Dr. Keith Matheny, and he goes, nope, we don't use a Vaseline in the OR anymore. Now, truth be told, I haven't been in the OR in my leopard clogs and scrubs since 2011. No, maybe 2017. So it's been a while. But here's why. Those petroleum-based products, people have used them for nasal moisturizing, but they carry a huge significant risk. I mean, they're popular because they appear effective. And they're widely available, they're inexpensive, and they're very familiar to patients. But here's the problem. Aspiration. Very, very small amounts of that petroleum jelly can be inhaled into the lungs. It's called lipoid pneumonia, and a chronic use can lead to an accumulation of lipids in lung tissue. It's very difficult to diagnose and treat, but it does increase with application, and especially in the supine position. So I'm going to just say it. All those people that are doing nasal release technique, slather up that balloon with Vaseline, shove it in the nose 4 times on each side, and then they inflate the balloon. We don't know where that Vaseline is going. So just err on the side of caution. The higher risk patients are children, elderly patients, and patients using CPAP machines, and also those with chronic nasal dryness. Renata, do you have any questions or anything you want me to go over again on this or emphasize?
Oh, this is amazing. Yes, but
Yeah,
we've been seeing so many of these nasal release techniques. It's crazy.
yeah, we're going to touch on that. But
Okay.
there are some safer alternatives to petroleum-based products.
Okay.
Saline gels, water-based formulations that hydrate without that lipoid pneumonia risk, that are safe for long-term use in the chronic dry nose conditions. Water-based moisturizers, that's where nasal cleanse comes in. Non-occlusive formulas that maintain mucosal health. different products that are ideal for post-surgical care and CPAP users. Again, that's where the nasal cleanse gel, and this is studied. So it's just not woo-woo. It's not Dr. Gale saying, oh, I love my product. We looked at this, we tested this, and I trust her. Room humidifiers that are maintained about a 40 to 50% humidity level. And that's really important. Even my house, I have at least 50% humidity in my house at all times, winter or summer. Because we really want to look at that source. What's causing the dryness in the nose? There may be an underlying source that we don't know about. Is it a metabolic disease? Is it a hormonal issue? What's going on? So that's where we have to do a little bit of investigation too. Not just say we have a dry nose, but what's the root cause of that dry nose? And then we have hyaluronic acid products. Now, hyaluronic acid is in our tissues. It's something that we have. And I used to sell a product called Sepra Gel and Sepra Pack. And Sepra Pack was, the fancy word, carboxymethylcellulose, chemical name meaning sugar water, and hyaluronic acid. Hyaluronic acid is a natural substance in our tissues. And we would use this packing in the OR for nasal surgeries. The whole goal of packing and using these different products in the operating room was to prevent what's called synechia. And synechia is basically scar tissue that's attached from the septum to the lateral wall of the nose. So that's the whole goal of sinus surgery. We don't want scar tissue in our nose because obviously we know what's going to happen after that. So just a quick summary of nasal products. We have saline sprays, steroids, decongestants, antihistamine type of sprays, combination therapies. We have to be able to choose the right product that depends on the symptom, the patient, the duration, and what's actually going on. So here are some controversies in nasal care products. And folks in the sleep space with mandibular advancement devices, you open up Facebook, there's always an ad. You open up Instagram, there's always an ad. And I tell my patients, stay off of social media. You can really put yourself in a panic attack just going through Instagram, all these different reels. We have to know our source of who is saying this. And I have to say, a podiatrist is not an ENT. Are they an MD, a DO, or a functional medicine doctor? Is it a chiropractor? I mean, yes, we have our silos. The body is always broken down into silos. And yes, we want to have about collaboration, but we have to understand the specialties of the people that are doing this and that are saying this, because you can get misinformation and have problems. And the problem we have on social media is that if you're not a licensed provider, and Renata, chime in on this. If you are not a licensed provider, what's the liability? I don't know. Do you guys talk about this in your world with like myofunctional therapy? And I mean, there's people that are not licensed that are talking about, let me tell you about tongue exercises and breathing exercises. Where's the liability for the common person who's looking for help? There's millions of people, they just want to breathe and sleep.
Yeah. All of
Tell
a
me your
sudden,
thoughts.
if you went through this yourself, or um, you're not a licensed professional, but you were in the field, and all of a sudden you can just jump on. I feel like most myofunctional therapists out there have enough hours of education to have a master's degree. It is insane the amount of courses and hours that we have put into this.
Mm-hmm.
It's really the responsibility of people teaching the courses, allowing just anybody to take them. Number one, that needs to be regulated in a certain way. With Airway Circle, we always follow everything that the IOM recommends. It's the only nonprofit association out there. So whoever they allow, we allow.
Mm-hmm.
But it's a mess right now.
Yeah. And so we get these nasal care products. You see it on social media. And they're like, well, I'm going to try this. I'm going to try red light and stick it up my nose. It's going to shrink my tissues. And I've had people ask me, it's called photomodulation. Like, what do you think, Dr. Karen? I'm like, let me test it and get back to you.
Yeah.
I love that. I love when companies come to me and like, can you test my product and see if it really works? And I'll be brutally honest with you. But these are some of the controversies, is that these marketing claims will outpace the clinical evidence.
Yeah.
And that's huge. And so we have to look at these key concerns. There are unsubstantiated claims, and I have to say it, nasal release technique, not one study to show safety and efficacy. It is not FDA cleared. It's not. The device is homemade and it's
Mm,
taking pieces, parts of class one products that are cleared by the FDA and putting them together to make a homemade device.
mm,
There's no science out there, and there's a lot of false product claims.
mhm,
And when we talk about regulatory, and I've worked in regulatory with medical device companies, and I'll tell you a funny story about a nasal gel. I was in room 4 at Washington Hospital Center with one of my favorite ENT surgeons, Dr. Pereira. So I have all the students and the residents, and I'm in my little happy self, the rep, like, okay. And he looks at me, he says, okay, Karen, so we've done the debriding and we're getting ready to close and end the case. What do we do next? I'm like, well, you use Sepra gel. And he says, or Sepra pack. And he says, what is Sepra pack? I said, it's a carboxymethylcellulose hyaluronic acid packing that is absorbed. And he looked at me, he goes, really? And I said, yes, because that's what I learned in training, y'all. He said, are you sure? And I said, yes, it's absorbable packing. He said, do you know who I am? And I said, Dr. Pereira, my favorite ENT surgeon. He was hilarious. And he goes, no, really, do you know who I am? And I said, Dr. Pereira. He goes, no, really, do you know who I am? I go, I give up. Who are you? He said, I work for the FDA. That one word could shut your company down. Bone does not absorb packing. It's a dissolvable packing. See? One
wow.
word could have just at the time it was Gyrus ENT before Olympus. One word could have really shut down. So this is why we have to be careful because
Mm,
that misleading terminology doesn't carry that automatic efficacy or FDA approval. Now, drugs are FDA approved, devices are FDA cleared. There's a difference, and I talk about this in my book. But we have to look at these critical red flags, Renata. If there's no published clinical trials in reputable journals, if they're using testimonials instead of actual scientific evidence, or if the language is very vague about natural, doctor recommended, and nothing specific, that's a red flag. So again, when we look at this from a clinical perspective and use, we have to look at these key characteristics. What each one of them does. What is the mechanism of action? How quick does it work? What's that safety profile? Then we get into prescription versus OTC. When do we escalate care? And this is really important with what you do, Renata. If a patient says, I've been using clear spray for 2 weeks and nothing happens, well, that's an over the counter option. But what do you do when it's not working? How do you escalate to a prescription level? And here's a few tips. If it's more than 2 to 4 weeks, then that's that's prescription. If there's a moderate to severe allergic rhinitis that requires these corticosteroids, if there's refractory, it keeps coming back and coming back, that's refractory. It just doesn't work. Or if there's suspected complications such as sinusitis or polyps, like I was saying. But also, we have to look at cost and insurance because some things are covered by insurance and some things are not. So you can see it's just not a simple spray. Clinical use, reimbursement. When do we escalate to something more aggressive? And here are some of those common misuse and pitfalls in nasal care: overuse, using beyond its time, poor spray technique. Let's talk about that for a second because when we look at spraying technique, nasal resistance will impede how the spray works, how it deposits
mm,
into the mucus of the nose, and the bioavailability. And I have a little thing on that. This is what we found in our COVID spray. So we did COVID research and we were formulating a spray container for a particular drug. And I just had a brain freeze. I can't remember it. Camostat. We were doing a camostat study. So we were using another company's nasal delivery device. And I said, this isn't going to work. Well, why? I said, because you're not measuring nasal resistance. And I said, let me tell you what the outcome is going to be. It's going to be inconclusive. And guess what? After the whole clinical trial, results were inconclusive. because we didn't know how much drug to dose, how much was working, getting into the tissue, right? So these are all these different pitfalls in nasal care that can happen. Here we go. How do we spray? Blow your nose. Shake the bottle. Make sure that the medication is properly mixed. Tilt your head forward. I know it's looking back, but tilt your head forward a little bit. Aim away from the septum. Gently inhale. Avoid sneezing. And remember, the proper technique maximizes drug delivery and minimizes the side effects, like a septal perforation, which I have seen with budesonide rinses. They are squirting this way and eroding the septum instead of squirting this way. So technique is key. But again, high nasal resistance affects the deposition of the drug, the bioavailability of the drug, the dosing, and even the plume of the spray. Here's what's interesting. 90% of nasal products marketed as clinically proven lack rigorous peer-reviewed evidence to support those claims. So a marketed product does not equal FDA approved, the drug side, or device FDA cleared. And an FDA clearance is not the same as an FDA approval. Remember that. Special populations in nasal care, we got to remember to protect our kids, pregnancy, because the saline rinse irrigation is kind of the first line for pregnancy, and also our elderly, because of the different diseases and comorbid conditions that they can have that could interact with those different sprays and medications. And one thing too, nasal medication delivery is becoming very popular, especially in diabetes. So that's a good one to think about as well. And again, with regulation and evidence, we have to understand that regulatory landscape. It's essential for evaluating these different products and procedures on how we clear our nose. So that being said, there is a process. There's FDA classifications. There's drugs, devices, and a combination. So if you ever have any questions, look under 21 CFR of the Food and Drug and Cosmetic Act, and that tells you everything: what you can say, what you can't say, is an approved device, not approved device, and that's why I was talking about the nasal release technique, that term for nasal balloons. It gets mixed up. Renata, I was shocked. There was a chiropractor on social media who compared it to balloon sinuplasty. Balloon sinuplasty is an FDA cleared device that goes in. It's only done by ENTs. No ENTs are doing NRT. So if the ENT doesn't do it, red flag. But that little balloon goes in and opens up the little ostia to help the maxillary sinus drain. That was launched in 2005, and we were kind of a co-launcher with Acclarent when they launched that product. It's come a long way. It's very cool. Why do some of these products lack the FDA approval? Because there's no clinical trials, nothing's randomized, insufficient safety data. There are undefined efficacy endpoints. So you can kind of see from a research perspective why some of these products are not even FDA cleared or approved. Clinical implications with limited evidence. Patient harm, patient trust. We need transparency. And the clinicians should be very clear and communicate the evidence and limitations to their patients. And if you don't have that clinical evidence, it's hard to communicate that. It's also hard for them to make an informed decision. And then we look at evidence versus marketing. Again, the red flags. Clinically proven, no citations, red flag. Beware of these testimonials over peer-reviewed data. And look at the critically evaluate the manufacturer-funded studies. A lot of manufacturers will fund their own studies to make themselves look good. So that's a red flag as well. And ask if there's an independent replication. So future directions, we continue to move forward. We look at emerging technologies as well. Also consolidate key takeaways, and new innovations are coming in nasal care and airway medicine with biologics, new drugs, AI diagnostics, personalized airway medicine, smarter delivery systems. So overall, our points today were evidence-based care, product misuse awareness, patient education, regulatory understanding, how we individualize therapy, and most importantly, how do we apply these principles. So I just want to give one quick case. If we have a rhinitis medicamentosa, 42-year-old patient comes in with chronic nasal congestion, the most common complaint, after using the oxymetazoline spray for 3 months. So what do? Taper the decongestant, gradually reduce frequency over 1 to 2 weeks to minimize that rebound effect. Start intranasal steroids, begin fluodecanase, and reduce the inflammation. Add saline and gel for moisture. And the key learning point is we eliminate that rebound effect and congestion. Again, the afrin is a huge problem. Create more patient education for further prevention of these problems and have a combination therapy. These are my references. This is my contact information, email, phone, and website. And I thank you. That was a lot. That was a lot. But I think it's so important, Renata, because patients are just desperate for answers. They want to breathe, they want to sleep. I see it on Reddit, some of the comments on the platforms. People are desperate. They will do anything. And I get people that come to me that just want to sleep and breathe.
Yeah. I mean, it's something that we take for granted if you can do it well. And
Exactly.
And the interesting things is that if you can't breathe very well, half of the time you don't even know that you can breathe better.
You know what? And that's that principle. So Pasolini's law, we don't really use it in my world because the nose isn't really a tube. This area makes more sense because it is a tube. But the nose has so many curves and with the turbinates and whatnot. It's called the Weber-Feichner law. Weber-Feichner law means...
Do you mind unsharing your screen so I can see you really big on my screen, please?
Oh, sorry. Stop share.
Boop. All right. There you go.
Yeah. So the Weber-Feichner law is saying that our response to a stimuli is different than our actual awareness of the stimuli. So we think we're breathing well, but we're not. But you put on like an intake nasal dilator and like, boom, I can breathe. That's because it's called JND, just noticeable difference. Just a millimeter at the highest point of resistance right here at the internal nasal valve area can create that just noticeable difference. And you're like, wow, right?
That's so funny. I thought I actually recorded a reel, just posted today, because I thought intake breathing, like the sizes are based on the size of your nose. And I know I have a big nose, but I still I'm going to do the small one. And I've always done the small one. And I noticed a little bit of a difference, but it wasn't like, wow, like I've seen other people. So yesterday I decided to try every single size. And it was insane how the biggest one was the best one for me. I like that one the most because it was like, boom. It opened up so much.
It's funny you mention that because that's another thing I see on social media. Level 1, level 2. And they're like, have a deviate septum, use level 4. Hang on. Here we go. The marketing message. Here's the problem. It is based on your nose, not your nose, but the alar width. So you hold it up to your nose. This is the alar width from here to here. You hold the band up and then you clip it on your nose.
Put it upstairs.
Why that matters is because a bigger nose doesn't mean better function and better breathing. We all have a pressure gradient. This is what I was talking about at Panny. We all have a pressure gradient in our body. We have like 36 to 40 pressures in our body. That book's coming out next year. But what's interesting is that the pressure drives the amount of airflow we get into our nose. If you make your nose too big, you can kind of create empty nose syndrome effects. And it happened to me. I was doing a live with them with intake. And I said, well, let's just see what happens on L1 because I'm an S2 girl, right? I put the S2 on. Oh, I can breathe. And then I put the L1 on and I threw myself into a panic attack on camera. I was like, oh my God, I can't breathe. So yeah, we put it under the nose to measure the alar width and then clip it on. And yeah, see, you did it. you could tell that just noticeable difference, like, oh, but if you lose that pressure gradient to slow the air down, it can move downstream and make you snore. Mm.
Ah, that's so
So,
interesting. And I wonder because before I had expansion, this measurement was a lot smaller. My nose was like this, and it has gotten way wider. So I wonder if now the larger one is better for that reason.
yeah, yeah, if it matches up under there. Yeah, yeah, yeah. Absolutely. Yeah.
Do you mind sharing really quickly the Davidson maneuver?
Oh, yeah. So we're all familiar with coddle maneuver. That's the internal nasal valve. And one thing I was sitting there, I'm like, we have two sets of valves, y'all. And this is a Davidson maneuver. You just gently take your fingertip, tip of your nose, just up, just a little bit, and breathe in and see if that helps. Because the external nasal valves are right here around the rim of our nose. And if we just internal,
Mm-hmm. It might, this
external.
one to me makes a bigger difference than this one now.
Yeah. So for me, I'm an external girl. So I move my intake down a little bit closer to my nostrils, so this pops out. What's interesting is that you'll see everyone when I just have to say it, y'all. When we sniff, everybody has a form of collapse because the negative pressure increases and pulls the lateral walls of the nose in. Okay. When you breathe really big sniffs, that higher negative pressure makes everything collapse. Okay. That's just physics. When you're using those nasal dilators, you shouldn't see your nostrils move. You shouldn't. People go, and I'm like, your nostrils will start moving. Move it down. Do you have the right size?
Mm-hmm.
It almost, in the ENT world, it's called a Denver splint. And it's something that we used in functional rhinoplasties or nose jobs. And it's a trapezoid shape and it has a metal on the outside with a cushion on the inside, and we bend it. And I told Alex, the owner, I'm like, oh my gosh, this is like a Denver splint. It is literally like a splint for your nose walls.
Oh my gosh, that makes so much sense.
Yeah, yeah, yeah. So,
And the last thing that I wanted to share, I noticed something this
yeah.
week. I have this little boy, I think he's about 8 years old, and he is just always with his mouth open. So he's seen an ENT. I sent him to an ENT first.
Hmm.
They did tonsils and adenoids. They removed them. Then he went to it was a dentist who did I think it was a functional appliance for expansion. I think it was a BioBlock. I can't remember, but it was that more of a slow expansion. And then he came to me for my functional therapy after he did all of that. And still mouth wide open. I just noticed something that I feel like I missed throughout most of the therapy. He wears glasses, and the glasses are always here.
Oh, there you go.
And I was like, oh my gosh, I think it's his glasses.
I think that's nasal function 62. I don't know.
Right? It's always here.
Wait,
Just
maybe
like
I
this.
think I think I put in there like the face and our behavior and how we choose a partner. I think I put, yeah, it's an eyeglass holder.
Uh-huh.
Yeah.
So interesting. I had never thought about it before. Well, Dr.
Yeah.
Karen, I know I have more questions for you. I do. Oh my gosh, I want to ask them really quickly.
Yeah.
Um, how does nasal resistance impact oropharyngeal collapse in patients with sleep apnea?
Yeah. So again, we all have a normal range of nasal resistance. Pressure drives airflow. Those two together create resistance. I mean, the mathematical calculation is R resistance is delta P pressure over flow. Um, here's the biggest misconception, and it drives me bananas. They'll say zero point 0.2 to zero point 0.3 is normal. That is so wrong. Y'all, we have about 253 variables that impact our nasal resistance. So what happens is the pressure gradient doesn't really move downstream, but the body compensates where that pressure differential kind of moves down the airway into that pharyngeal area. So if the resistance is high and airflow can't get in, it increases negative pressure, the tissues respond. That's why I know I upset everybody and probably hurt feelings in the sleep world, but sleep apnea is not a skinny pipe. It's a pressure flow relationship. How does that pressure impact the surrounding structures? Right? So if you have increased intrathoracic pressure, it's sucking everything down. If you
Mhm.
have a bad tongue, that's not, and it could be a tongue tie release that went bad. I've seen that
Hmm.
happen. The
Yeah.
negative pressure, I presented that Panny, where the negative pressure sucks the tongue back into the throat because the tongue is either unstable, weak, or it wasn't a frenuloplasty that didn't really need to happen. You
Hmm.
know, we got to look at all these, flow pressure relationships. So that's what's happening. Increased negative pressure cause everything to collapse.
Hmm. Or a small maxilla, because if the maxilla is too far back, especially too far back, if it's protruded, the
Hmm.
hypoplastic maxilla, you can release the tongue, but then the tongue's going to fall back because it doesn't have a place to go. You
Yeah.
gotta make
Yeah.
sure.
What's interesting is you say that in kids, anatomically, and I would say children are not small adults. When you look at them anatomically, and again, I talked about that in Panty, and even in my book, I think I have a picture in there. I'm not for sure. I do in the new book. But kids, how I treated an airway emergency in a pediatric patient was completely different than an adult. Why? Their tongues are already larger. The oral cavity is already smaller. The nose is less protrusive. The jaw is already retrognathic. They're already to compromise just in their anatomical space without anything happening. That's just how they're
Mhm.
built.
Yes, I
Yeah.
think that the soft tissues grow to its most until age 8, and then the skeletal structure doesn't catch up until 12. So in between that age 8 and 12, you're gonna see a little bit more. Everything's so big for the structure that they have if they're still growing normally, but everybody's already underdeveloped.
Yeah. And that's what happens with nasal resistance. It's very high when we're babies. And by the age of 5, it drops by 50%. So,
Really?
yeah, so we see high nasal resistance and then it drops. And then around ages 3 to 4, when the immune system kicks in and the adenoid tissue is developing, that we see a slight uptick of nasal resistance at the ages of 3 to 4. Then it drops off around 5, 6, 7 years old, 7, 8, 9. It kind of picks up, picks back up again. And then it drops off at 10, craniofacial development, right?
Mm-hmm.
Then it picks back up again around prepubescent years,
Yes,
puberty with hormones.
yes.
So it's a flux. So we have to, when we're doing expansion, all these different things on children, we have to look at those pressure changes and create the treatment to form the biology. Don't force the biology into the treatment
Mm-hmm.
because you can have a reverse effect. Hmm.
Wow. Wow, wow, wow. All right. Tell us a little bit about your books. Where can we find them? How can we find you? How can we work with you?
Oh gosh. Okay. So drkpd.com, drkpd. It's like a radio station, drkpd.com. But I have everything there. I've got all, how to get a hold of me,
Beautiful.
on my depository of work, how to contact me, what you want to contact me about. And yeah,
Awesome.
drkpd.com.
Thank you so much for hanging out with us
Thank
today.
you.
You're always blowing my mind
Mwah.
every single time that you speak. Keep doing
And
what you're doing. You're doing amazing things. God has a beautiful calling for you. Don't listen to the naysayers. You're going to do amazing things in life, and I
love
cannot wait
that.
to be there to cheer you on always.
And I always say, breathe easy, sleep well.
Thank you so much. Bye, everybody. Happy Thursday.
Bye. Happy Thursday.
Oh my gosh, hold on.